Hi,
Hi, Abby.
how are you?
I'm great. I'm so happy we're finally doing
Oh
this.
my gosh, this has been an reschedule for months and months, so I'm very happy we're doing this too. And we ironically, unplanned, ended up having a dress rehearsal last week because we got to be at a seminar, a summit together.
We did. We did, which
Yes.
was a lot of fun.
So, Dr. Rachel Mandelbaum, you are a fertility doctor. Did you always want to be a fertility doctor?
It's funny. I always wanted to be an OBGYN. I was always interested in kind of the female experience and felt like that was always kind of a calling for me, working with women and just sort of invested in everything that comes along with being a female, right? And OBGYN always felt like, you got this honor of being a part of all these really momentous life experiences. And so that's kind of what pulled me to OBGYN. I actually thought I was going to go into oncology, to gynecologic oncology. And then I discovered reproductive endocrinology and infertility through the research side of things and really felt that it's one of these fields that has progressed so much over the last, it's wild to say, but 40 years. And it just felt like there's so much still that we don't know. And that felt very motivating to me. Now, at times it in practice, it can feel frustrating that we don't have
Sure.
an answer for everything. But from a scientific perspective, from a medical perspective, I think there's a lot of opportunity to really make a lot of measurable impact in people's lives and kind of discover things and ways to improve fertility treatments and our successes and all of that. So I find that very motivating, and that's kind of what led me here.
Do you still do research? Like, are you still one of these? Do you spend some of your time doing research? I know you've presented posters before at seminars because we've been together for one of those. What fuels your passion for research? Like, what do you love researching?
Yeah, I still do a lot of research and everything from kind of translational research in the lab and studying embryos, and that's really what kind of fuels that intellectual curiosity. I mean, human reproduction happens in a black box, right? So with fertility treatment, we see that up close. We don't know why some embryos become pregnancies and some embryos don't. Even some of the most beautiful embryos don't turn into a pregnancy. And we don't have the answers there. And I find kind of melding the laboratory aspect where we're able to kind of push the envelope and understand or try to understand some of what we don't know. I find that incredibly interesting. And I also think we have some of these very basic questions about kind of human existence, right? What is it about the embryo that allocates a cell to the part that will become the baby? What is it the part that what is it that allocates a cell to the part that will become the placenta? We still don't know a lot of these things. And it's kind of wild if you think about it, that we know the ins and outs of all of these different diseases and diabetes and all of these things. And there's so much research going into it. But because human embryo research is politically charged, it's difficult to do because we don't get a lot of embryos to just research. These only
Mm.
come from people who've completed their families and would like to contribute their embryos. Um, it's a slow process, and so I do work on embryo research, and then I do a fair amount of clinical research. So trying to understand what IVF protocols work the best and achieve the best outcomes. Same thing for frozen embryo transfers. And then, we'll talk about it, but needle-free IVF has been a really big research interest of mine. So really everything kind of from the bench to clinical.
Love it. And when you became an REI, do you have doctors in your family? Did you always was part of the reason you wanted to be an OBGYN forever because you had doctors in your family?
Yes. My family is all doctors.
Okay.
So, kind of from a young age, I grew up in empty hospital beds and, coming in with my parents to, when they got called in the middle of the night and all of that. My mom is in family medicine and my dad is an orthopedist. And so I kind of had these two examples of somebody who was very general and kind of never, could never knew what was walking in the door, right? Could take care of an 80-year-old man to a 2-year-old female, right?
Hmm.
Very different. to somebody who is very, very specialized. And I always was drawn to being the master, if you will, of something that was very niche and specialized.
Hmm.
And I think, I fought for a little bit against kind of doing what my parents did, but I felt like that was what I knew is just that when they came home at the end of the day, they were super tired, but felt so gratified in what they had done that day and the role that they had played in people's lives. And that's what I wanted out of a job, something that didn't feel like a job. It felt like a calling. And I tried other things and they just didn't make sense for me. So here I am.
Yes. Okay. It's very meant to be if you know you. It seems like, of course, this was your path. So
Yeah.
let's talk about let's go backwards. Let's talk about needle-free IVF and then go into how your maybe we'll hear about your personal story and how it impacted. What is needle-free IVF?
So, needle-free IVF is a way to do IVF without the injection component, right? I first kind of saw IVF as an outsider, if you will, and it just seemed like such a process. I personally hate needles, and we can talk about my story a little bit later, but I just I was in the medical world and I was kind of astounded at what patients were being asked to do with IVF. And I felt like women are so strong. We will do anything if it means a baby is waiting for us on the other side, right? And I knew that, and I have full confidence that, we can do the injections. But I felt like this process just seems so antiquated. Why are we doing this? And why isn't there a better option if people hate injections, right? And at the same time, I feel like there are so many stressors of this process, right? How many eggs are you going to get? Are they going to materialize to embryos? Are they going to be transferable embryos? Just a lot of anxieties and stressors, and the injections, I feel like just compound it. So needle-free IVF basically uses a small sticker-like device that we place on the abdomen. This is what it looks like.
Yes.
You wear it on your abdomen throughout stimulation. And basically, all the medications are exactly the same, but instead of injecting them with multiple injections per day, you can put them through this tiny little device. You basically remove this little cap and you attach this tubing, and your medications are in a syringe like this, and you just push them through. And there's this tiny little flexible cannula that sits right under your skin, under this sticker. And we put this in the office. And so all the medications can go through here. So you never have to give a self-injection at home. Everything goes through here. And my patients really, really love it.
Okay, so that what's it called? A candula? What did you call it?
There's a lot of different words.
Okay.
I tend to refer to it as like a catheter, but I know you were telling me before that
Yes,
it always reminds you of a Foley catheter.
exactly.
But we can call it a subcutaneous port, a device,
Okay. But that
catheter,
little
whatever.
tiny thing hanging from under the sticker, that goes into the skin. So it's
Yes,
just that
this
one
is
shot
sitting right.
needle.
This is sitting right under the skin, and we put it in with a small device in the office that looks like this. So you basically stick it onto your abdomen, press the red button, it goes like, and it goes in less than a second. It's way less painful than an injection because it's so quick. So we put this in the office. Patients wear it for a week at a time. So usually they're using two catheters per stimulation, per IVF cycle or egg freezing cycle. We change it out here. So you just don't have to, be doing all of that at home.
Wow. Okay. And so that sticks onto you. So let's say you have 10 days of stims, you do five, switch, do five more. So that's your two.
Yeah, exactly.
Oh my gosh. I mean, I feel like this is so revolutionary. Like, how was this not? I mean, I'm happy for you that you thought of it and invented it, but how was this not thought of before?
I think it took a true needle phobe having to do IVF. I don't
I mean,
know.
I think of so
With the
many.
doctor and kind of like, thought of, well, okay, so this came to me. So it's all very fortuitous, is the truth, right? So I happened to know that I was going to be going through IVF, and I was a resident at the time. And I was working with women who had type 1 diabetes who were pregnant, and they were in like a high risk OB clinic that I was working in. And I remember talking to one patient who had just gotten an insulin pump, and she was like, I hated injecting myself so much. I am so much more happy and relaxed now that I have this insulin pump and I'm not having to poke myself. And I was thinking about IVF looming over me, and I was like, why can't something like this exist for IVF and all these shots? And then I was like, wait, voila, this should exist. And then had some time for the idea to kind of percolate and figure out how I was going to do it, and then tried it on myself. And it went great. And then,
Like
it
you
was,
did a whole cycle of IVF with this as a guinea pig, yes?
yes, yes.
Like what if it hadn't worked?
I mean,
I
I don't
mean,
know. I guess I knew that it would is the thing. Like why would it not, right? Like we use this for insulin. There's data that exists that shows a good correlation with when you inject insulin, what happens to glucose. There's data already existing for other medications that go through it, showing us absorption from the skin is no different. Um, so I really just had really high confidence that it was going to work. I wasn't too worried about it not working, and if it hadn't, I guess you could say I'm in the field, so
sure.
I have some connections that might
Yes.
get me a redo opportunity here.
Yes.
But it just made my experience of the process so much better. Like I was going through the process actually kind of alone because my husband at the time was doing his fellowship in Northern California. And so just injecting myself would have been a no-go. Like if
Mm-hmm.
I would have done it, I would have done it, but it would
So
have come
funny.
at a big, anxiety cost for me.
Wow.
Or I would have found a friend to do
Yeah.
it. But yeah, and it went great. As great as can be. We've talked about this before. I have, very low ovarian reserve, so I knew that IVF was not gonna, be very efficient.
Mm-hmm.
But it went great. And then that opened the door to a clinical trial that I had kind of been dreaming of for quite some time, where we took patients who used the catheter like I did, and compared them to patients doing the needle injections. And from a research standpoint, IVF is the perfect, or ovarian stimulation for IVF is the perfect way to study a device like the catheter because um, it different than like diabetes where you give insulin, right? And then you're watching kind of the response in an indirect, right, cause and effect something. So you're watching the response in glucose levels, right? With IVF, we're just monitoring, we can measure all the hormone level that we're giving through these injections in the bloodstream because with IVF, in the majority of women, we are trying to suppress those hormones, same hormones, FSH and LH that come from the brain, right? We're trying to suppress those. So those are not present in high levels when we're doing this process, and we can really just measure everything that's coming from the injections or the catheter.
Mm-hmm.
So it's a very easy way to prove that this
Like
works.
efficacy in real time,
Yeah,
basically.
that everything that we are giving through an injection, right, is really reaching the bloodstream, hence the ovaries, in the way that it should. And so it's a very clean study, so to speak. And that was beautiful. I mean, we found that there were no differences in hormone levels between the catheter and needle injection, and really just proved that it works just as well.
Okay, so let's go quickly to the clinical trial. How did you find your guinea pigs? And
So,
how, like, what are the sort of ground rules of a clinical trial? It seems overwhelming, obviously, because I'm not in the medical field. How do you go about getting one set up? And then who did you find?
yeah. So when you do a clinical trial, you have to obviously go through all of the regulatory, organizations and boards. So you go through what we call the IRB, which is the Institutional Review Board. And we went through that at USC. I was a fellow at USC when I started this, and then now I'm faculty there. And so I've done a lot of my research there. And then also, you have to register it with clinicaltrials.gov, which is the
It's an
government
actual thing.
body,
Okay, see, I know
yeah,
nothing about
that
this.
that reviews clinical trials and makes sure that they are safe and conducted in a good and fair way, to protect patients. So it takes a long time to get one approved. So this was years in the making for final approvals. And basically, you have to demonstrate, why you think this will work, why you think that it is not more harm than benefit to patients. So really what I had was my own experience and then this data using insulin and some other medications where they had had very good success. And I was like, look, we know that these medications get into the subcutaneous area, right? The area under the skin where we inject them just as well. So why would this be any different for the medications with IVF? And everybody agreed. And then in terms of, so we got approval. And then in terms of recruiting patients, I really just, maybe it's self-selected, but as soon as patients heard about this study and the opportunity to not inject themselves, it was so easy. I actually had zero, honestly, zero patients that I approached about the study who didn't want to participate.
Mm.
And I think that that just shows how big of an issue it truly was and is.
Yeah. I mean, I think from my own research and data, I would say it's number two on the list after money. It's like money is the biggest barrier, and then people who are afraid of needles to IVF, you know?
Yeah, so actually, and we're going to be hopefully publishing this soon. Then after I did this study, right, I kept saying, look, people are so scared of needles. And people will be like, but are they? And I was like, yes, they are. Trust me. Okay, you don't trust me. I'm gonna prove to you with data, right? So I stuck a survey in the HRC waiting room, right? And had everybody coming in, right? Whether it was for IVF, egg freezing, just tell us about their anxieties, rank their anxieties. Is it cost? Is it, success of IVF treatment, meaning number of eggs and embryos getting pregnant? Is it vaginal ultrasounds? Is it blood draws? Is it giving yourself a self-injection? Is it time off of work? All of these things that go, relationship anxieties, all of these different things that go into the stressors involved with IVF. And as you said, self-injection of the medications were the third top anxiety following money. And is this going to be successful?
Mm.
And and two-thirds of people had significant anxiety surrounding needle injections. And of those two-thirds, 20% actually reported significant delays in coming to seek treatment
Because of needle fear.
because of their fear of self-injection and needles. So
Wow.
that's a huge issue, way bigger than even I thought, right?
Mhm.
That two-thirds, almost 70% of people have significant anxiety that if you rate it on these scales that are kind of a validated scale to predict a phobia of something, they're meeting the criteria of a needle phobia. And not only that, but of those two-thirds, which is not an insignificant number, that people were delaying coming into our office or choosing to pursue fertility technology because we have left this as such a, um, you know, unpalatable kind of anxiety-provoking process.
Mm. Mm.
So that's just not okay. We have to
Right.
improve it. We have to improve it.
Right. And like you've said to me before, we just assume as women that they'll grin and bear it and they shouldn't have to.
Right. I mean, I feel like we talked about this the other day, right? That I feel like this has been my gripe with a lot of OBGYN and women's health is that I feel like pain and going through all of this has been kind of, you know, we are expected to go through it as part of the female experience, right? And IVF falls so much more on the shoulders of the female partner than the male partner. And we're like, oh, that's unfair, but it is what it is. And yes, some of that is biology, right? I accept that.
Mm.
Um, but that doesn't mean we can't do everything that we can in our power to alleviate some of that, to make the experience better. And that's just so pervasive in everything from what birth control options there are to on labor and delivery. I mean, actually, this is a quick aside, but I find this interesting. So my husband is an orthopedic surgeon. When I was in training, he and I were talking about the pain control medications that we give to patients when we are doing a painful procedure. And we were talking about the dosing for morphine or fentanyl that we give when he's reducing a bone versus when I'm doing, a procedure like a dilation and curettage or something like that. And to me, those are both very painful things, right?
Yeah.
And he was giving so much more medication than I was trained to give that made me question everything. I was like, how is it that I'm not giving the same amount of medication that you do safely to reset a bone, right? As when I'm doing a procedure on someone's uterus, right?
Yep.
And that is just the problem. That is
Yes.
the problem, is that we expect women to just tolerate it,
Hmm.
right?
And I mean, to go down the rabbit hole even further, no men have ever had to experience it. So no men, did trials on it. So no men, I mean, now that we are experimenting more on women and adding them to clinical trials, we can get this data to know that it's equally painful. It's just
Totally,
crazy.
totally.
Um, okay, so just let's stick with needle-free IVF. From a business perspective, did you trademark this? Like, how does that piece of it work?
So this is existing technology, right?
Okay.
So this is a device that exists. It is off FDA label, right? So this is an FDA approved device for other indications, and I'm using it off label for IVF. Now the idea of kind of needle-free IVF is something that is in the process, right? Trademarking. But this is something that is still kind of experimental, if you will, but works really well. Like now I do this, I offer needle-free IVF to all my patients, and 70% use it. And they have great success with it.
Hmm.
So I feel very comfortable offering it.
If somebody's terrified of needles, of which there are many, do you feel like they would fly in from across the country to do this, or could you send them the device and train somebody else to do it for them?
It's a good question. I mean, we'd have to figure out kind of all the logistics of it. I mean, if they're willing to fly, then
That's
fantastic.
ideal.
That's ideal.
Yeah.
But we'll figure it out.
Yeah. But I know that ultimately you want this to be in clinics everywhere. Would you offer some kind of training for it? Do you think you could your nurses train? How do you think it would
So that's
go
the
down?
goal. So my goal here is to start developing a program, right? Where I can train other people based on my experience and the years that I've kind of gone through trial and error of how I've seen this work best. Where I can train people's nurses, train the clinics, get them the devices, all of this. So that's the goal. That's what's coming down the pipeline is I'm hoping to make this more widely available. I really feel like there's so many women that can benefit from this. And particularly for the women who are considering egg freezing even, right?
Hmm.
I think egg freezing is one of those things, and I've seen it in my friends and my family. It's one of those things you're like, I'm gonna do it next month, next month, next month, because it just feels like such a big,
Hmm.
you need a
It's
big
like
push to
hanging over you, this thing
hanging
you
over
have
you.
to do. Yeah.
Totally. And I think that making this process seem just, again, a little bit more friendly, a little less anxiety provoking, can really help. And I think this also opens the door. Like, can we, create other technologies for remote estrogen monitoring? Can we, really use these devices to our advantage here to make IVF as a technology more accessible and more patient friendly?
Amazing. Now back to your own story. How did you handle it when you found out you had diminished ovarian reserve? And what point of your medical career were you?
So I was finishing my residency, and I knew that I was going to be staying at USC for fertility fellowship, and I already, having a life with a two physician household is not easy, right?
And wait, just to confirm, your dad was an orthopedic doctor and your husband's an orthopedic doctor? Okay, just making sure I wasn't making that up. Okay.
Yeah, yeah. And now they work together. So it's
Amazing.
a little wild. But it hasn't been easy, right? To figure out how we were gonna create our family, how we were gonna do that, balancing two careers, all of that. So I knew that he was going to be leaving Los Angeles for fellowship. I was going to be staying, and that we were going to be delaying having kids even further. And I was like, well, let's freeze embryos. I think that that's, the best course of action here. We're going to be starting our family in my mid 30s, and we wanted a big family. Um, and I always have this conversation with patients that, if you want a big family and you're starting that journey in your, mid to late 30s, that you really have to kind of be prepared, right? If it's really important to you to have, multiple children, and there's a chance that you are going to be trying in your, late 30s, early 40s, that is hard. And so you just want to be prepared with a plan A, B, C, D. And now that we have this technology, I think we can look at it in the lens of preparedness,
Mhm.
right? So I very frequently now have this conversation kind of based in my own experience of let's prepare for baby number three, right? Before even we're addressing number one, if it's important to somebody to have that big family. So we decided we wanted to freeze some embryos. I just got my ovarian reserve checked and found out it was really, really low. And my AMH was zero point 0.6 at,
Um,
29, 30. So really, really low number of follicles. So basically what that means is that it doesn't have any bearing on your natural fertility, but what it means is that going through fertility technology and IVF is very inefficient. It just means that every cycle you're going to be getting a lower number of eggs, and it's harder to withstand that funnel that is IVF. And when you're young going through it, you have much better odds because, the percentage of, let's say, 6 eggs, right, that are normal is going to be much higher than if you're coming back to do this in your late 30s, when not only, let's say, am I getting 3 eggs, but now
right.
a much higher percentage of those are going to be abnormal. So it's much better if you have a low ovarian reserve to be doing this when you're younger and have the benefit of egg quality. You kind of get a lot more bang for your buck, so to speak.
Which, by the way, you know this about me, my literal life plight is getting AMH tested at age like 20 and 25 standard, then maybe 28, then 30, whatever. But like the fact that people go into their 30s, maybe they haven't even met their mate or decided if they want children and they have no clue what their AMH is, there's no reason for that. It's so easy.
Right. And I think it's very important that it comes with the right counseling. Like, I think,
Right? We don't want to trigger
somebody,
people into thinking something's wrong, but
yeah,
not if we know that knowledge is power and knowledge makes you empowered to make smart decisions, let's get the knowledge.
totally. And I think, then at least we could have a conversation of, okay, if your goal is just one baby and you're probably going to be having that baby in your early to mid 30s, then I'd say, okay, then, if you're going to be needing IVF, then maybe it's not that big of a difference where it's not worth that crazy investment financially, right? So you know, I do acknowledge that not everybody has to go the path that I did. But if a big family is really important to you, and if you know that you're working with low numbers to start, then you may change the way that you go about that journey or live your life, right? You may choose to delve into having a baby sooner. You may choose to freeze eggs or embryos, right? So I just think it gives you an actionable opportunity, right? And I agree. I think knowledge is power. So when I found that out, though, I scream from the rooftops and tell patients all day long that AMH egg quantity does not predict your fertility. It really does not. And we know from the data that people with a low AMH, people with a high AMH, they get pregnant at the exact same rates and same time to pregnancy. Um,
But when it was you,
But when it was me, and when you find out anything about your fertility, right? It's not actually measuring your fertility. And that's my biggest pet peeve is when the AMH test is marketed as a test of your fertility. It's not. The only test for your fertility is trying to get pregnant. But when you find out anything about yourself that you didn't know that is related to your ability to potentially have that family that you want, it is earth-shattering. And so I really identify with people who feel that anxiety of seeing that that number is lower than they expected. And and so I freaked out. I was like, oh my God, let's get some embryos on ice. And I ended up pulling my IUD at the time because we didn't have as good data at that point that, IUD didn't measurably change outcomes. Now we have a couple studies that have kind of shown it might be okay to keep it in, still in women who have a lower egg number,
AMH.
more of a conversation.
Yeah.
Um, but I chose to pull it and wound up pregnant trying to freeze embryos. So I am the poster child for AMH does not predict your fertility. I'm also embarrassingly the OBGYN that had an unplanned pregnancy, but this unplanned pregnancy is my whole heart. I mean, he's, my first son and wouldn't have changed anything. And, I needed that push, I think, to
Hmm.
have a baby. It was hard because then we went through long distance with a baby.
Mm.
Um, and then came back after I had him to freeze embryos, and that gave me time to prepare to do needle-free IVF, right? To figure out how I was going to do that and figure out all the kinks and so it was all really just fortuitous the way it happened. And then we went through IVF and now I have two kids and those embryos that we created, will be good hopefully for baby number three.
Hmm.
But it's been a journey and it's been a journey on a personal level, professional level, all of it.
Which I think is so important. I didn't personally realize that I wanted a doctor who'd been through it until I met with one. And it just changed everything for me. There's just a different level of understanding and empathy. There just is, just the reality.
Yeah, I mean, it it really, really is different. Like when somebody is having a hard time with those weights, like the wait to find out genetic testing results, the wait to find out if they're pregnant after a transfer. You just understand it, right? I mean, I had a patient who was texting me um, twice a day with unfortunately her embryo transfer didn't work the first round, but texting me, morning and night with negative pregnancy tests. Do you think I'm still pregnant? Here's my negative test. And I get it. I mean, I spent $300 on pregnancy tests,
Right.
right?
Right.
And so I really get it. Like I can tell her, don't test, you're gonna drive yourself crazy. But
Hmm.
I get it. You
Right.
can't help it. Like I've been there.
Totally.
I totally get it. So, yeah, I do think having been there and having that experience does kind of change my outlook on, you know, how I care for patients and the conversations we have and all of that.
I love to ask people, sort of in closing, what is there a piece of advice or something maybe your parents told you, or as a doctor, maybe something you tell your patients that you think about often or that you repeat in your head like a mantra?
Yes. So one of my favorite quotes is that you must participate relentlessly in the manifestations of your own destiny. And I love that quote. I know you must participate relentlessly in the manifestations of your own destiny. And I feel like I have so many people coming in here saying, is this whatever divine powers will? Am I not supposed to have a baby?
Right.
I'm not supposed, why is this happening to me? And that quote just makes me feel like I have to fight tooth and nail for what I want to happen, right? And I have agency here. What I do matters. And at every step of the way, right? The modifiable, factors that we talk about, supplements, diet, exercise, all of these things that we modify about our lifestyle too, right? That we have agency here that we sometimes have to work really, really hard to make our dreams come true. It's not just going to happen. And how wonderful for those couples that snap their fingers and they're pregnant. But I think that trying to remember that sometimes it takes a lot of persistence to make our dreams come true, whether that applies to fertility, that applies to career, that applies to everything, right?
Mm.
And I think just that's something that kind of kept me going in my personal life and something that I often will talk to patients about who are finding it hard to, keep moving in this journey. I don't know, I just really love that
It's a
quote.
really good one. It's a really good one, and I've never heard it before. Thank you. Thanks for being here. We're going to link out to everywhere and everything. And if anyone needs needle-free IVF, you know where to go.
Yes, thank you so much for having me,
My
Abby.
pleasure.
I love our conversations always, but this one
Always.
is really fun.
It was a really good one.